844. Its goals are providing relief from distressing symptoms, easing pain, and enhancing quality of life. Now for hospice care, with 6 months or less has lived a certified physician. So to be eligible, you have to, the physician has to say you got 6 months or less to live. So if he's saying you got a year, you're not going to qualify for hospice yet. It has to be 6 months or less. Hospice can also be hospitalized, or it can also be in your home where you have a hospice nurse come to your house every day. That's up to the family to decide where they want their care done, whether it's at home or whether it's at the hospital. Some people don't want it done in their home because they live there after the person's deceased and they have a hard time getting back to daily living, because when they go through the living room, that's all they see is that loved one there in the wheelchair or the loved one on the couch. So they have a hard time if they leave them at home. But if they move them to inpatient at the hospice hospital, then usually the dying is a little bit more easier. Everybody returns back to normal living. It's just a little bit more better. But you do have that option to keep them at home. Just depends on what the dying person wants. I'm under eligibility for hospice care on page 845. If somebody survives beyond 6 months, he or she continues to receive care. So just because you go over that 6 month mark, like the doctor didn't anticipate, they're not going to cut your care off. You're still going to get the care that you need until you do die. But it should be physician documented 6 months or less. While receiving hospice care, the client can transfer to another hospice program, but may not be discharged because of the inability to pay high cost or treatments. Palliative care ordered by a physician or because of difficult behavior. So palliative care is done in the hospital. This is where they withdraw all treatment except pain medication. Okay? You're not going to get O2. You're not going to get any food. You're not going to get any IV fluids. All they're going to do is give you pain medicine. Okay? Now, you should still have people coming in and swabbing their mouth, keeping their mouth moist and, keeping them clean and giving them a bath. With palliative care, we're not doing any nursing treatment. No tube feeds, no medications, no nothing. They are just there to receive pain medication. Does everybody understand that? Yes.
Why do they still do vitals on palliative when you report them and they go, well, we're not doing anything anyway? Why do they do that?
Because they want to see how close that they're looking
gross.
at. Yeah. Because, so say you should only be doing vital signs every 8 hours, because the physician will still round every 24 hours and he'll look at those vital signs. And you all know as nurses now that you all can tell when somebody's blood pressure is low but their heart rate is high. That's a sign that death is near, right? So that's another reason why we look at vital signs, is to tell, how close is it. Now, vital signs is not going to give us a definite. Somebody could hang on for months like that. Now, if you're looking at O2 sat, that could be a little different, because the O2 sat looks at what? The oxygen level. So if somebody's O2 sat is low, we know they don't have much oxygen, they don't have enough RBCs floating around their body. That time, it can pin it down a little closer, but it's mostly used for the professionals to look and see how much time they got. Sometimes insurance requires that we document what their vital signs are on this day, and then they'll come back and look at them again, and they might say, I don't know if this person really qualifies for this or not. Just looking by vitals. So it just depends. How many people they got coming in needs a bed versus what they got there in front of them. So it just depends on what they're looking for. But yes, we should do vital signs for our own information. Hospice service on page 845. Hospice service organizations also provide support programs for family members and significant others. So not only do we take care of the patient, we also provide services to those families. Hey, look, you can go here and get help. You can get financial help here, or you can get medical help here. Some people get under anxiety a whole lot when somebody's dying and they don't know how to handle themselves anymore. So we can send them, hey, you need to go to the doctor and get you some anxiety medicine, or here, go over here and get you some financial help, or these people will help you with the grieving process. So but it's our job